Hello and welcome in today's nursing webinar session. Myself Shanti Bhattacharya, the VP Nursing, and we are going to talk about the surgical aspect of breast cancer. As you all know, this cancer is surpassing the other cancers as well in the society. And if at all it is not detected and prevented and screened early, then we may have its prevalence by 2030 very more. So let us see. Let me just welcome the marvelous pioneer of surgical oncology, Dr. Sachin Ji. He's our surgical oncologist, clinical director, and senior oncologist, robotic surgeon in Yashoda Hospitals from Somajiguda unit. Let me also welcome my oncology nurse, who is Miss Leena Shrivastava, who is very dedicated, contributed, and she is very readily accepted to talk in this webinar session. I appreciate you for this. Welcome, Leena. So let us go for the first slide. Yeah, as we are going to talk about, you can share the first slide. Yeah, as we are going to talk about the question which we would like to understand from you, what is the key facts about this prevalence and, WHO update on this condition like breast cancer. So how
Yeah.
far we have come and how far it is prevalent in the, society. Yes.
Yes. So first of all, let me congratulate all our team, Shanti and Leena and all our nursing staff and our digital team, Pawan and all. They are taking strides long. I mean, more than 2 years now. We are listening about these different webinars in different aspects of healthcare, and I'm very happy that not only us, but not only Yashoda staff, but also it is going beyond many areas, including many countries outside in Zambia, Kenya, and all. Just now, I got one message from our Kenya hospital that they are also listening this webinar. So I'm very happy for all those things. And as just Shanti Madam has expressed her concern regarding the increased incidence of breast cancer, this is a good opportunity to discuss about the prevention, because prevention is the key. And I'm also happy that recently we celebrated Women's Day on 8th March. So in conjunction of this, not only we should celebrate as a womanhood, but also we should celebrate women's health. So this is one more attempt from Yashoda Hospital celebrating women's health by creating awareness about women's health. So I congratulate all the team and let us start. So yes, the key facts about breast cancer is all of us know that is increasing. There are various reasons. First of all, in olden days, when we were residents, say 20 years back, 25 years back, it was like uterine and cervical cancer was more common. But now that slot has been taken up by the breast cancer. There are various reasons. Now, if you ask me about the particular incidence or prevalence, it's almost now the rate is so alarming that I can say now every one woman in 20 can have a breast related issue. It could be benign, it could be in situ carcinoma, or it could be malignancy also. So that's the way it is increasing. And especially now, we always talk about the cancer means is a Western world disease, European disease or US disease. But now in India, as a clinical practitioner, we are seeing day in, day out that breast cancer incidence is increasing.
Yes. So let us see what we have in the rest of the session. Leena, you can take over. Go for the second slide. Yes.
Good afternoon, everyone. This is Leena Shrivastava. I'm working in chemo daycare as an oncology nurse. Today, we are going to discuss about the surgical aspect of breast cancer. What is the breast cancer? According to the WHO, the breast cancer is a disease in which abnormal breast cells grow out of control and form a tumor.
So, sir, here we would also like to understand, maybe many of our fresher nurses may not know, these, like when you can see in the blue, box, breast cancer cells begin inside the milk ducts and it spreads. And then if there is a lumps or thickening. So should we go with this criteria when the patient comes and objectivity they say to you? Is that the true factual symptoms, sir?
Yes. So, see, in layman's language, what is cancer is abnormal, uncontrolled growth of cells. For every cell in our body, nature has given one particular lifespan. For example, RBC, red blood cell, will live for 120 days. After 120 days, it will die automatically. That is called as apoptosis. But in cancer, what happens? There are some epigenetic factors, maybe genetic, maybe environmental factors, because of which the cell which will has to die after one particular time, it may not die. It will just go on increasing and then reproducing one cell to two cell, two to four, and it will form a lump. So the important here, as Shanti Madam has expressed, that not every lump is a cancerous lump. So this is very important, because many times we get a patients who have a lump in the breast, suddenly they become, panic and anxious because they think that could be a cancerous lump. But most of the time in young age, around 20, 30, because of hormonal issues, there will be some lump in many young girls or women. They could be fibroadenoma, small lump, which is there, which is not progressing in size. So these lumps we can just need to observe. No need of any, going panic and getting it done removal, not required. Just we should be aware that there is a lump. Just keep observing it, and if required, just get a clinical opinion from the concerned doctor.
Yes. Yes, Leena.
Coming to the risk factor, what are the risk factors? The family history of breast cancer, the risk of breast cancer, the mutation in certain genes such as BRCA1 and BRCA2. The most common women diagnosed with breast cancer do not have a no family history. Exposure to the estrogen for post-menopausal women, HRT and menarche, consumption of breast control pills, etc.
So, sir, are these the risk factors which will be always, potential possible for the woman to get the BC, like when we are talking about the, this breast cancer genes like BRCA1 and 2. So what is your, insight about this again?
Yes. So what Leena has mentioned, these are risk factors, correct? But most of the time, the genetic, as you told, BRCA1, BRCA2 is only around 10 to 20% cases it is positive. I hope we all remember the Angelina Jolie, correct?
Yes.
She is from USA, and she's a star, and she had this particular gene was positive, and she got herself prophylactic mastectomy. Like before the disease come, she got removed the both breast and then reconstructed with the plastic surgery. So that is called as prophylactic mastectomy. In India also the incidence is around 10%, but now the awareness so much that we are keeping those patients under follow-up. Not every patient needs prophylactic mastectomy. That is number one. Number two, when we call it as a hereditary disease or familial disease, there is a misconception. A lot of patients, they come to me and they say, in one person in our family, somebody was there. So can we have the risk of breast cancer? So here I am clarifying that doubt for all of us, that if there are more than 3 members in family, more than 2 generations having the same cancer, then it could be familial cancers. Not only one particular patient or some distant relative has a cancer, some esophageal cancer may not have a breast cancer. So either breast or ovary tumor in more than 3 people in the family and more than 2 generations. So that we have to remember. Second thing, what she has mentioned is absolutely correct about the estrogen. I mean, early menarche, late menopause. So the overall estrogen exposure to any particular female may increase the risk of breast cancer. And very important, which I feel now we are seeing, is obesity. So obesity is also risk factor for breast cancer, is also uterine cancer. And one more thing I am seeing now, recent phenomenon, is like smoking. All of us, we know that the incidence of smoking is more in males, but now we are seeing, because of a lot of societal pressure or peer pressure or following just blind trends or some thrilling, even many women now they are smoking, and that is also one of the important cause for breast cancers. So these are most important risk factors.
So, sir, here my one insight I would like to even check with you. Like, if at all the prophylactic mastectomy, how one should decide that they or she should go for prophylactic mastectomy? Should she only depend on the mutation of BRCA1 and 2, or something else, or all this risk factor she can go for prophylactic mastectomy?
We are not very much proponent of prophylactic mastectomy, 7-8 years back when Angelina Jolie got diagnosed, there was like, it is also called like Angelina Jolie effect. That time the internet, even Google searches also went very high about this breast cancer, BRCA and all those things. Yes, because it's kind of any celebrity when they gets diagnosed, people they follow them and they search about them and all. But we are not that much, hard and fast to get it done, prophylactic mastectomy. Only people who are not able to follow up, they are staying in the remote areas, they will not able to come to the doctors, they are very poor and health illiteracy is there. For them it is okay, but those who can are regular kind of follow up and are little cautious about their own health, we can just fairly observe them
Yes.
with this BRCA1 BRCA.
Coming to the diagnosis, the early detection and screening protocols. The mammographic screening for those aged 40 to 74 years, then 50 to 69 years were regarded as the optimal age group. The breast ultrasound is used as the first imaging modality in young age above 30 years, the breast cell examination.
So, sir, if someone, we have a pre-puberty girl and adolescent girl, right, from that age till 30, 35, and 40. So, one should follow these detection and screening protocol. What is your concept in this?
Yes. Yeah. So these are our standard guidelines, right from European countries, US, and even in India, that up to 40 we can do a sonography. After 40, 45 we can do a mammography annually, yearly. Now, why we are saying sonography, not mammography in young age? Because this is childbearing age. So we don't want unnecessary, even if it is small amount of radiation, but still we don't want it to be on the breast because they are young, they want to raise their family and breastfeeding and all. So up to 40 years, yearly sonography is sufficient. But after 40, 45 years, mammography is important, annual. Now we also tell that digital mammography is little more sensitive and specific, not like a conventional mammography. So even small lesion also the digital mammogram can pick up. Second important thing is, now there is very common myth in society that if we do so many mammograms every year, is it harmful? So many patients they every year. It is not. Is it also radiations that can also induce cancer? What should we should do? So I just clarified. Mammography just like very small dose of X-rays which are done for the soft parts. So it is not at all harmful. The radiation exposure is very, very less. So annually screening mammography is mandatory for every female after 45-year age. And other very important point, Leena has mentioned that breast self-examination. There are two things, clinician breast examination and self-breast examination. So any female, for that matter, 40, 30, 35, 40, they can have their self-breast examination. There are various methods which are available. You can go through that. There are some circular technique or there are some zigzag techniques. They have to, just palpate with the uh, flat part of the hand, not with the tips. And one should understand their breast consistency. Many female, they have nodular breast. So sometimes they feel that it is a lump. So they should understand first what is the normal breast and then accordingly they can do. And normally we advocate this breast self-examination on the around 10th day of their menstrual cycle so that it is non-tender and soft, and during taking bath they can undergo this. And also they should create awareness in their society, in their female circle group, to get this breast self-examination regularly and mammography regularly.
Yes. Very importantly, this has been explained very beautifully by you, sir. I think everybody, whoever watching this webinar, should emphasize on doing so. Yes, next, Leena.
Coming to the sign and symptom, the new limb or mass in the breast or underarm area, changes in the breast size or shape, breast pain or tenderness that is persistent and not related to the menstrual cycle, changes in the skin texture of the breast such as redness and dimpling, nipple changes including inversion, discharge, especially bleedy or clear fluids, or itching, swelling or thickening of the part of the breast, and other usual changes of symptom in the breast area.
So, sir, I think you must have already witnessed these kind of, patients coming with one or the other symptoms of such. Any other
Yes,
unusual changes or anything new, which is now you get to see, sir? Anything else?
yes. 90% of the time they come with the breast lump. But here one important point I want to mention that they are painless lump. So if there is a pain, then we should be happy that it is not cancerous, because it could be because of fibroadenosis or cystic mastalgia during menses. And as Meena has certainly mentioned, that it is not related during the menstrual cycle. So any painless lump which is there since long time, which is increasing slowly in size, is, our antenna should be out. It should be alarm, so that you can check yourself and go to a doctor so that they can proceed with some investigations. So to confirm whether it is benign or malignant. And many other important things, blood color discharge. Many females have normal serous discharge or white color discharge. That is perfectly normal during because of the some hormonal changes in young age. But if it is blood color discharge, dark or chocolate color discharge, sometimes it could be related with the cancer. And so that we can also look into that matter.
Yes.
Otherwise, these are fairly common signs and symptoms of any breast lump.
So these are the types of breast cancer we get to see. I think all of the nurses, they are also aware. Maybe if
Yes,
at all you're not aware also, these are the types, and one must, at least try to find out what kind of surgery is being operated on the patient. So, sir, I think these are the breast cancer type, and we would
yes,
like to know which is very common among which age group of female, and
yeah,
which is very dangerous and fatal, where the
yeah,
prognosis and recovery is, delayed as per the
correct.
states. Yes.
Correct, correct. Very important question, because not all cancers are same cancers. They have their heterogeneity, they have their biological behavior. Some are low grade, intermediate grade, high grade. And many times the KI index, which is the marker of the grade of the tumor, is also important. Most commonly, we see invasive ductal cancer, carcinoma, which arises from the milk duct, almost 70%. And then some cancers like lobular carcinoma and in situ carcinoma, also around 10 to 20% we see. But very important is little aggressive cancer is triple negative cancer, because they don't have the markers to give adjuvant therapy. So whenever any patients who have a triple negative like ER, PR negative and HER also negative, so these cancers are called as triple negative cancer, and they are little resistant. The chances of recurrence are more, the chances of metastasis is more. And very important is we don't have any particular chemotherapy or drug available still now. So we have to be little aggressive in this, and these are almost 20 to 30 patients can come into this triple negative bracket. And HER2 positive, fortunately, we have now the antibody against it. So we give that injections for year for HER2 positive patients. Inflammatory breast cancer, here it is for all of us, it's very important that inflammatory means it is infection, but here it is a misnomer. Inflammatory is not infection. Inflammatory is, it's little the redness of the skin, it is little advanced, the chest wall is little red, ulcerated, fungated. So that is inflammatory cancer. And metastatic, as we know, it's already spread to the body.
Yes, Lee.
The treatment modalities, the surgical intervention, radiation therapy, hormonal therapy, chemotherapy, and targeted therapy.
So I think, sir, we will also see the surgical interventions one by one. But then I think these are the treatment modalities and advancement which happens nowadays in healthcare industry and treated by you all. Yes.
Yes. Yes. So it depends on the cancer stage. If it is early stage, stage 1, very early tumor, then definitely only monotherapy. That means surgically treatable patients. They may not require adjuvant chemotherapy or radiation if they are very early stage. But if it is stage 2 onwards, then we have to have multimodality treatment, where we discuss the case in our tumor board meeting with the medical oncologist, radiation oncologist, and pathologist, and PET CT consultant, and of course the patients. So, what are the pros and cons of each and what is the pathology report, and then depending on that particular area, we plan the adjuvant treatment. So surgery, radiation. One more important thing here I wanted to, just when we do breast conservative surgery, then definitely radiation is mandatory. So any female they want to conserve their breast, they have to be prepared for further around 20 days of radiation when we are planning breast conservative surgery. Hormone, as we discuss ER/PR positive patients, we give those tablets. They are very simple. The patient can take at home, very minimal side effects. And chemotherapy has multiple regimens. I'm sure Leena must be seeing a lot of patients and she can also tell about it. Targeted depends on the targets, which receptors are expressed, and then we can give medicines accordingly.
So targeted would be just precisely very accurate, only targeting those abnormal cells by not destroying the normal cells, you mean, sir?
Yes, exactly. So, for example, HER2 positive patients, we have the trastuzumab molecule, which will only go into that abnormal mutated cells and it will control it without damaging the normal cells. So, side effects profile is very, very less. Patients are much comfortable during this treatment. And also, I'll may, because the now topic is there about the chemotherapy. Normally, now we are putting a chemotherapy port. So that the patients, those who are undergoing chemotherapy, we know we cannot use the same hand because already we have removed the nodes on that area. So we avoid the pricking on that area. So we take the chemotherapy, put the chemotherapy port so that there are less chances of thrombophlebitis, extravasation, and also patients are quite comfortable. There is no the acceptance for taking chemotherapy, and the side effects profile is less. So it is better to counsel the patient for chemotherapy port, and it has to be also maintained. I'm sure Leena and her team is taking care about it.
Yes, yes.
Next.
The surgical intervention.
Just a minute. Leena. These are the surgical interventions, as sir said, that, lumpectomy, simple mastectomy, and modified radical mastectomy, and radical mastectomy, sir. So these are the only surgeries, sir, we do, as you said, as per the condition of the patient and staging.
Yes. So lumpectomy, normally we do it for the small lump, benign lump, fibroadenoma or giant fibroadenoma or something like that. So that is for benign tumor. But when it comes for the cancer, breast cancer, there are different options, as she has mentioned: mastectomy, modified radical mastectomy, and breast conservative surgery. Or now now, for example, modified radical mastectomy is remove the whole breast along with the nipple, areola, muscle, and also axillary nodes, level 1, level 2, level 3 nodes. That is modified radical mastectomy. Now we are doing more of breast conservative surgeries, and now one more terminology has been added, that is oncoplasty surgery. So onco is cancer surgery, plasty is plastic surgery. So combining these two on the same time during the surgery, so that is called as oncoplasty surgery, because now we are getting many patients who are young, and they are like going to the office, teachers or IT worker, and they have their social life. And every woman, breast is a symbol of your confidence, their body language, and
Feminism, yes.
yeah. So we try and counsel the patient to undergo breast conservative surgery or oncoplastic surgery, and there are many plastic surgery reconstructive options available. Sometimes we put the implants, sometimes we put the muscles from the abdomen, tram flap, abdominal flap, or sometimes just external prosthesis. So these are different prostheses are available. So when any patient comes to us, so this is our part of counseling. Like many patients, they ask, what about if I lose my breast? Or what any option to conserve my breast? So now all patients, we spend some time to counsel them about the pros and cons of each, and then let them take a call what they want, what is best for them.
I think we'll take you more quickly, Leena. Yes.
Then conservative breast surgeries. Additional treatment are required, such as radiation therapy, chemotherapy, hormonal therapy, and targeted therapy.
As you said, sir, these additional treatments are required with the conservative, yes. Next.
Yeah.
What is the reconstructive breast surgery? The breast reconstruction using body's own tissue or restore the shape of the breast after a mastectomy.
Yes, this also already we have explained
Yeah,
about the
that's- yeah.
conservation and reconstruction.
The nursing care pre and post surgery. The pre-operative assessment. Preparation the patient should be kneel per oral, then consent and documentation. Ensure that the patient has signed informed consent for the surgery and complete all the necessary document accurately, then hand over all the reports and imaging to the OT nurses. Then post-operative care, the pain management, assess and manage post-operative pain. Then wound care, monitor the surgical incision, site for the symptom or infection, then hematoma, etc. Then provide wound care, then drain management, assess the drain output, maintain drain patency, activity and mobility, encourage yearly.
So here, sir, as you were mentioning, not to use the unilateral or bilateral limb if at all it is operated for any type of phlebotomy work, like putting IV cannula or giving the IV fluids or drawing the sample. I think that is the very important thing which we would like to tell all the nurses sometimes. Not also this, even the dialysis hand as well. Anything else, sir, we all should be careful, like bedside nurses, in terms of managing this patient post-operative.
Yes, it starts right from the before the treatment when a patient is in OPD with the counseling because they have a lot of anxiety and mental issues. So we have to counsel them about this. Second thing, marking and all already Leena has mentioned about the fasting, NBM and all those things. And as you mentioned, avoid phlebotomies or any blood sampling, drawing from that area. Post-operatively, one already she has mentioned everything, but one or two aspects that we have to mobilize the patient as early as possible. And initially, that part will be little tender, little painful, but we have to encourage the patient to do the arm from the second post-operative day. And very important is the drain management. Many times we see the patients, sometimes accidentally the drain gets pulled out and they may not able to manage that. So we have to counsel them during the intraoperative or postoperative they when they are in the wards, so that about the drain care, about the measurement also very important. We have to show them how to measure the drain in a syringe so that they can put a count about it. And very important is lymphedema management. I'm sure you have seen many patients in your practice, in your things, that when a patient got operated post surgery, post radiation, the lymphatics get blocked. So from day one, we have to tell them to do massage and lymphedema therapy and keep them active. They should not use the rings or bangles in that particular area so that it not get infected and swelling there. Uh, Strong deodorants or strong powders or strong chemicals they should not apply around the axillary area so that skin should not get irritated or infected. All those things have to be taken care.
Yeah, these were very valid points you have mentioned. I think I'm sure even I was not aware of this. But certainly we will follow this, sir. And I'm sure, Leena, you will also teach your, oncology nurses for the same what sir has been mentioned just now. Yes. Next,
Yeah.
I think we have come to the end. Yes.
Post-discharge patient education. Advice to take adequate rest. Advice to do regular exercise such as shoulder bend, squeeze, slide bend, chest fall, stretches, etc. Avoid weight lift, regular medication and follow-up. Discuss the further plan for care.
So, sir, I think these are the post education you all provide, and until further of plan of care, also I think they did discuss with you on.
Yeah. So here one thing I want to add that many in our Indian scenario, any family who undergo surgery, our people who are they want, they always no you take rest. This is a surgery happened, so you take bed rest, don't move, this, that. So many patients, their relatives, they will advise them. But here we have to tell them that you have written adequate rest. That means whatever adequate rest, not like a bed rest and also we have to keep them ambulatory. They can go in the house, they can go into the garden or in the terrace, They can do all those stretches and exercise. And uh, as per the follow-up, they have to come to the hospital. Then we'll remove the drain, we'll remove the sutures. If there is any infection, we'll just keep monitoring and giving antibiotics. And then once the final pathology report comes, then we'll again meet with the patients and relatives to decide with further treatment plan. And here, one more thing, I think, Leena, you should tell all your patients about the management of chemo port. So you have to explain them that the port and the cleaning and the flushing every monthly or 3 monthly, correct?
Yes, sir.
Yes.
Yes, and then I think we have come to the conclusion, sir, and all nurses in Yashoda and even entire healthcare industry, I think mostly all majority of the nurses are female workers, and it is very ideal that they all are watching this webinar and all preventive measures to be taken. And we would like to hear the conclusion part from you as well, sir. The image which we are showing is that enough, or should we also conclude by any other means of communication?
Yes. Obviously, now you told that all women and nurses and all, but let me add one more point. Even male do get breast cancer.
Yes.
Yes.
Yeah. So 1% in of breast cancer also in a male. I have treated more than 10-15 patients in last 10 years with the that is a normally our mindset is
Yes.
a male won't have breast, so they will not be a breast cancer, but male do also get breast cancer. So just watch out for that or increase awareness for that also. And I think it was a wonderful seminar, and I'm sure all of us got more enlightened with many of the major issues, but also minor issues which we have to take care of it. And yes, definitely together we can win our cancer. It's just uh, multimodality treatment. And again, I am mentioning that very important is interdepartmental communication. Most of the things have a problem because there is a misunderstanding or the communication is not proper. Oh, I thought this. Oh, I thought you know this. Or that kind of things happen many times in the hospitals. So we should have a proper protocol, as she has already mentioned, taking tick list of everything, and then I think we can give best to our patients.
Yes. So, sir, again, one more thing which we would like to understand is now having, undergoing MRM and all, what is the, concept in India that, availability of processes, because the patient have to also have the affordability as well. So, I mean, is it so simple that they get after the surgery and then they're comfortable and, they start living their life again? Because maybe the woman who has undergone this, maybe she's unmarried and, or maybe the woman who is not even, conceived. So are these modalities are easily available? Because you're the one who can always, tell this.
No, I didn't understand the question. Which modalities?
Yes, a prosthetic availability of prosthetic
Yes,
implants.
prosthetics parts, na?
Yes.
Correct. Very, very pertinent question as far as the breast cancer treatment is planned. Yes, the prostheses are available. So in my OPD also, we have a processes just to tell them there are different processes available, right from for poor patients also to the those who are affordable patients also. So there are multiple prostheses available. They are silicone, they are gels, implants, and one more important thing is many patients now they are undergoing breast reduction mammoplasty or breast augmentation mammoplasty. This
Yes.
is one point. This is just this kind of prosthesis which are available, which normally we tell the patients to have just feel about it, and if they think that it is they want them, then we can make it available. But here one more important thing I want to tell, that now many women, many young female, they are getting their breast either augmented because it's small size, or they are getting breast reduction because big size from the plastic surgeon. Now in such patients, it is very, very difficult to identify the breast cancer because the anatomy is distorted. They are not like a normal breast. They are little harder, their fibrosis will be there. So in such patients, we have to be little more careful regarding this. Second thing, for such patients, mammography won't be the ideal modality of screening. So for such
Detection.
patients, yeah, so such patients we ask for breast MRI. Yeah, a normal mammography may not detect it. So MRI for the breast augmented or any surgery for that matter, if the patient undergone and now they want to see, then it is ideal modality would be the breast MRI. And one more thing here I want to add, suppose any patients have a surgery, breast implant done for breast cancer, in future, also for the follow-up, we use either MRI or PET scan, not the mammography, because the architecture distortion would.
I think this information was very important, and I thank sir. Thank you, sir. Beside of your very important, valuable time you have contributed for the nurses and nursing webinar, and thank you so much. And thank you, Leena. Thanks for your beautiful, presentation. We end the session here. Thank you.
Thank you. Thank you.